The following podcast is part of a certified educational activity titled Challenges and Changes with Targeted Options in CLL, Guidance on Making Evidence-Informed Upfront and Sequential Treatment Choices. Access the entire activity and complete the post-test at peerview.com/XPA860. Downloadable slides and practice aids are also available.
Welcome and thank you for joining us for Challenges and Changes with Targeted Options in CLL, Guidance on Making Evidence-Informed Upfront and Sequential Treatment Choices. So as many of you know, there have been several major phase 3 studies looking at the use of targeted agents, both in treatment-naive and relapse refractory CLL. Obviously, being ibrutinib as the first to market, covalent BTK inhibitor, you have the Resonate-2, Illuminate, ECOG-1912, and Alliance. All of these major phase 3 studies showed superiority in PFS over traditional chemoimmunotherapy. Then we have acalabrutinib, we have the Elevate-TN, Ascend, and the Elevate-RR study, and again showing superior PFS for acalabrutinib over either more conventional chemoimmunotherapy, and the Ascend trial also over an arm that included a PI3 kinase inhibitor with idelalisib. And then sooner, obviously younger in maturity, is zanubrutinib with Sequoia and Alpine, again showing superior PFS versus traditional chemoimmunotherapy, and then in comparison to other head-to-head data showing superior safety profile with ibrutinib. And then moving away from covalent BTK inhibitors, we have venetoclax, a BCL2 inhibitor, and the major study that we all focus on tends to be the CLL14 venetoclax obinutuzumab versus obinutuzumab chlorambucil, and in the relapse setting, the Murano study with ven-rtux versus BR. So here, focusing on continuous BTK inhibitor-based therapy versus fixed duration BCL2 combination with ven monoclonal antibody. Despite these advances, obviously there's a lot of work to be done yet in CLL, although we're thankful to have these new targeted agents that really have transformed what we do for our patients. But there are still things that we notice, and so chemoimmunotherapy is still being given quite regularly in practice, both in the US and in Europe as well. And so here's a more recent update with the ERIC showing that about half of the patients are still getting chemoimmunotherapy in a recent real-world analysis. In the Informed CLL registry, we still see a lot of chemoimmunotherapy being given for patients with unmutated status, as well as folks, which is, in my head, a big shame, those who have a deletion 17p or p53 mutation are still not having recommended NCCN guidelines in the sense that they're not receiving targeted therapy and really should be. In addition to what we learn, we know that for patients who are starting to receive these therapies, we're seeing some resistance that is developing with BTK inhibitors, covalent BTK inhibitors, and this also will complicate, and we'll discuss this later, will complicate some of the treatment decisions that we make for our patients. Typically, patients, and these are tests that can be done commercially available if they're not done at your center. A lymphoid-resistant mutation panel can be sent, and BTK C481S or PLC gamma-2 mutations tend to be the most common. There are patients who don't have either of these mutations but have evidence of progressive disease, either a rising lymphocyte count or some growing lymphadenopathy. So typically, you'll see this in somebody who's been on a covalent BTK inhibitor somewhere around the 4 to 6 year mark. That's usually what I tend to see in my practice. And then, of course, we have a newer entity. We have double-refractory CLL. There's a new clear unmet need. So these are patients who have already developed some resistance to a covalent BTK inhibitor and also had a BCL2 inhibitor, i.e. traditionally venetoclax, although there are newer ones being explored on the market. But certainly they can develop resistance as well, and there are papers looking at resistant mutations there as well. And so certainly these patients, there's more difficulty in finding suitable lines of therapy for double refractory patients. Patients progress very quickly and do poorly with subsequent lines of therapy. So this is clearly a new unmet need that hopefully we'll address with newer agents. So for today's agenda, obviously we're going to talk about head-to-head evidence and safety with targeted agents, future of targeted platforms with novel combinations, optimizing sequencing, and we're going to do some cases as well at the end. A lot to do in 40 minutes. Okay. So when we talk about the advent and success of continuous BTK inhibitor-based therapy, our more mature data sets come from the Resonate-2 study with ibrutinib. We now have 8 years of follow-up, and now acalabrutinib, much more mature data with Elevate-TN, now 5 years of follow-up. And you can see here that the median PFS has not been reached versus more traditional chemotherapy with chlorambucil or chlorambucil obinutuzumab. So again, nice long data set showing a very good follow-up and nice PFS data for patients receiving chronic continuous BTK. Zanubrutinib being the newer to play in the field. So certainly we have shorter follow-up, but definitely we have also PFS benefits seen when we look at that in the Sequoia study versus bendamustine and rituximab. When we look at our high-risk patient population for continuous BTK inhibitor-based therapy, you can see that we now have accruing and substantial data on patients who have a TP53 or deletion 17p, both with ibrutinib, acalabrutinib, and now even zanubrutinib, who might have the larger cohort of this higher risk patient population. And you can see here again the median PFS not yet established for most of these studies, and showing superiority to more traditional chemoimmunotherapy, which should not be given for this patient population. And then switching gears from covalent BTK inhibitors, we have the CLL14 study. So obviously this is fixed duration treatment with venetoclax and obinutuzumab versus chlorambucil and obinutuzumab. And again, the estimated PFS was 63% for the ven obinutuzumab arm compared to 27% in the obinutuzumab chlorambucil arm. And you can see even in the patients who have high risk features with deletion 17p, you could see that they're doing very, very well, although with shorter follow-up compared to the chronic continuous BTK inhibitor studies that I showed you previously. So I'm going to pass this over to my colleague here, Deb Stevens, to talk about safety management with targeted agents.
Thanks so much for the great introduction. And all of us know that these drugs have led to really great benefits in increasing progression-free and overall survival in these patients. What we haven't touched on yet is the toxicity profile of these agents. And, I like to think that, it really takes a village to manage these patients. And so these are toxicities that everyone on your team should be aware of, and your patients should be aware of prior to starting these therapies so they can help you to monitor for these side effects. But I like my nurses to know about these, the nurse practitioners I work with, so that they can help when the patient calls in with side effects, because sometimes just a little bit of coaching can help prevent dose reduction of these agents. Over on the left-hand side, you can see common toxicities seen with BTK inhibitors. And I like to think of them as toxicities that you'll see early in the treatment management versus, throughout the course versus, are more common later in management. But arthralgia and diarrhea, nausea, sometimes dermatologic changes, fatigue, these are all things that you see most commonly during the first part of therapy, so the first month or two of therapy. And they do get better over time, and so just encouraging patients to get through these. Things that don't change over time are pretty consistent. The bleeding and bruising. A lot of patients will get petechial rashes with these therapies and need to be aware of it should they go into an elective surgery, their risk of bleeding. The cardiac toxicities of atrial fibrillation and hypertension really increase over time. The longer the patient are on these drugs, the more risk they have of having this. And of course, you've heard of the ventricular arrhythmias that were seen with ibrutinib, but also recent reports are showing some data that might suggest that acalabrutinib also has this side effect. Conversely, over on the right-hand side, you can see adverse events to watch with venetoclax therapy. All of us have heard about the tumor lysis associated with venetoclax, and Nicole is going to talk about some combination therapies, and I found in combination this is much, much lower risk to happen, because if you can debulk the patient's disease before starting therapy, it's a very significantly lower risk. GI effects and myelosuppression are common, and we'll talk about some of the management of this on the upcoming slides. So first, shifting back over to BTK inhibitors, again, these cardiac toxicities are really important to monitor for. I often am asking my patients, have you had palpitations? Do you feel your heart racing? Because these patients do get paroxysmal AFib, and sometimes you have to put them on a cardiac monitor in order to determine this, because often, when they're sitting there in your clinic, they are in sinus rhythm, but definitely have history concerning for atrial fibrillation. I mentioned that these drugs have a risk of bleeding, and so then, of course, you should not put these patients on warfarin as anticoagulation, because early clinical trials showed some very severe and life-threatening bleeding when using these drugs in combination. However, I have used this safely in combination with the DOACs or other oral anticoagulants, which you just have to really carefully monitor and make sure the patients know that they're aware of their risk of bleeding. Hypertension is the next one on the list. I've really had to, put my internal medicine hat back on and manage these patients, because often it's fairly refractory hypertension that you see over time. And a lot of times these patients have to be on more than one blood pressure medication. And so it's really great to have a great relationship with the patient's primary care provider, their cardiologist, so they can help you manage. And, a lot of, primary care docs, they may not realize that the BTK inhibitor is what's driving this hypertension. And so working together is a really good idea. And of course, monitoring for signs of bleedings and educating patients when they go on treatment. If they have an elective surgery, they need to contact you, because there's a certain amount of time before and after a surgery, depending on the invasiveness of the surgery, that you want to hold drug. Over on the right-hand side, I've highlighted a couple of things that are a little bit more specific to the second-generation BTK inhibitors, although could happen with other drugs. Headaches are very common in the first couple of months with acalabrutinib. 40 to 50% of patients experience this. They're usually very effectively managed with just Tylenol and caffeine. And again, some encouragement for the patient that these will go away over time. I try to have people avoid using ibuprofen except for in short doses, just secondary to increased bleeding risk with the drugs. Quoted in clinical trials, neutropenia is a little bit bigger issue with zanubrutinib. I do monitor patients' blood counts when they're starting therapy, usually weekly for the first month, and then monthly. And then after that, I monitor them on an every 3-month basis. Try to prevent dose reductions or dose holds, and just use G-CSF to help boost up their neutrophil counts. And then, as always, these patients, any patient on treatment or not should be monitored for infection and other secondary malignancies. We have some very nice head-to-head data comparing the first-generation BTK inhibitor, ibrutinib, with second-generation BTK inhibitors, acalabrutinib and zanubrutinib. I've highlighted a couple of key points from these studies here. The Elevate-RR study was done for patients with relapsed or refractory CLL, and patients were randomized between acalabrutinib and ibrutinib. Highlighted here in red are those rates of atrial fibrillation occurring in 16% of patients receiving ibrutinib therapy, which is a pretty high number. And still a high number, 10% in patients treated with acalabrutinib, but a lower rate, so a little bit less on the cardiac toxicity there. This study also showed a lower cumulative incidence of hypertension, bleeding, diarrhea, and arthralgia. So all in all, the study showed similar efficacy, but decreased toxicity with using acalabrutinib. Kind of a similar study, the Alpine study, looked at patients with relapsed or refractory CLL and randomized them to either zanubrutinib or ibrutinib. You can see the rates of atrial fibrillation in general were a little bit lower on this study, with 10% at ibrutinib and 2.5% with zanubrutinib, which is quite low number, probably close to the background of these patients who have CLL. And so overall, this body of data with the Elevate-RR and the Alpine data have really kind of shifted people from using ibrutinib right up front and using a second generation like acalabrutinib. And this is actually reflected in the most recent update of the NCCN guidelines as well. Other really important person on your team is your pharmacist, because there's a lot of different drug interactions with these drugs. So having the pharmacist review their current medication list and look for things like strong or moderate CYP3A4 inducers or inhibitors, and making the appropriate adjustments are very important. Also letting your patients know if another doctor wants to start a medication on them, just to kind of give you a heads up, and so you can make sure that there are no interactions with their drug, because that could either decrease the efficacy or, alternatively increase the toxicity of these drugs. And then a big deal has been with acalabrutinib. Previously, the original formulation needed stomach acid in order to digest this medication and have it be effective. However, the FDA has just recently approved a brand new formulation. This is an immediate release film-coated tablet and suspension. And that prevents that issue with using it, the drug with proton pump inhibitors. And so this is something to be aware of and consider adding this to your institution's formulary. Venetoclax monitoring, usually the most aggressive monitoring happens during the first month that the patients are on that, and that's mostly related to their tumor lysis risk. And so all these patients should be evaluated in terms of, how high is their white blood cell count, how big are their lymph nodes. You may need to get a CT scan to see what their internal lymph node size are. Making sure that patients are very hydrated and using antihyperuricemics such as allopurinol, and really frequent monitoring. And now again, Nicole's going to talk about some of the combinations coming up, and really those combinations in debulking their disease before starting venetoclax is actually very highly effective. Venetoclax does cause cytopenias. Neutropenia and thrombocytopenia are both seen. In terms of neutropenia and thrombocytopenia, I try to avoid dose reductions. If I can use GCSF to prevent a dose reduction, I will. And then GI events are common, but usually very easily manageable. Diarrhea is seen, can use antidiarrheals for this, and nausea is seen. And I've found that if a patient's experiencing nausea, if you have them move their dose to the evening, and so that nausea mostly occurs while they're sleeping, it's usually a little bit easier to tolerate. And then, of course, venetoclax is often used in combination with CD20 monoclonal antibodies, and these combinations are really prevent you from being able to respond adequately to vaccines, which, of course, is really important in this era of COVID. And I'm going to hand it back over to Nicole.
Okay, so let's talk about combinations. Obviously, the exciting topic that is here at the meeting and other meetings and congresses that we've recently had. Obviously, there's a rationale for using oral combinations between BTK and BCL2 inhibitors, and there's obviously a differential effect with these different agents. Venetoclax more effectively clears out the marrow compartment. This is why you can obtain complete remissions and MRD negativity in the bone marrow. And so this is a unique aspect of why the combinations with venetoclax can be time limited. There's obviously a little bit of a non-overlapping toxicity profile, although, as Deb had mentioned, you can have a little bit of myelosuppression and neutropenia with some of the BTKs, and certainly you can have myelosuppression with venetoclax. So it's something to keep monitoring, but obviously something that's manageable. There's a potential for reduced resistance during the combination therapy. Obviously, that remains to be seen long-term as we get longer follow-up data from some of the combination studies. And obviously, we know this could be a highly effective time-limited therapy given the response rates that we're seeing. So let's just go over some of the study. There are many, but just to give you an example, obviously, let's talk a little bit about the Captivate study. So this is fixed duration ibrutinib and venetoclax. They have a 3-month ibrutinib lead-in, and then the combination with venetoclax occurs. They take 12 months of ibrutinib and venetoclax in combination. There are actually 2 cohorts of this study. So this is the fixed duration cohort where everybody gets the 3-month lead-in with ibrutinib and then the combination for 12 months, and then everybody stops therapy. So this is a little bit of data from the fixed duration cohort. So here you can see we now have about 2 years of follow-up data. So again, everybody takes therapy for 15 months, and then they've been followed for another 12 months approximately is what we have on the data. And you can see that the responses are very similar, whether patients do or do not have a deletion 17p. And then on the right, you can see that here's the time period of when patients are off therapy, the treatment period in gray, and then on the right in white. And so you can see all patients, whether with or without deletion 17p, the PFS so far at 24 months has been about 95, 96%. So far, very good. Everybody's off therapy and doing well so far at the 2-year follow-up. Obviously, we're going to be waiting for longer follow-up to see how this matures, but very nice data with this fixed duration cohort. Now, what about, there's also an MRD cohort. This is the second cohort that I was alluding to. And patients are actually randomized. So if they have undetectable MRD, that subgroup is randomized to either go on placebo or randomized to continue with ibrutinib. Then there's actually another cohort for those who do have MRD detectable disease. They are randomized to either continue ibrutinib or randomized to continue ibrutinib and venetoclax. This is just the folks who have the undetectable MRD at the end of the 15-month therapy. This is a little data from that cohort. You can see here that patients are doing very well. There's the blue line is those that would continue to ibrutinib. The orange line is those that continue on placebo. The one-year DFS rate is about 95% on placebo versus 100% on ibrutinib. No significant difference yet. We're obviously going to follow over time to see if the curves, how they go about. Will there be a greater split over time? But you can see that in 95% in patients with confirmed undetectable MRD, everybody is doing well. So stay tuned for longer follow-up of these types of studies that I think will be very important. That'll help guide us about what to do with not only the patients, but also will certain subgroups fall out differently depending upon their disease characteristics. And then more of an international study, this is the GLOW study that looked at ibrutinib and venetoclax versus more traditional combination chemoimmunotherapy with obinutuzumab chlorambucil in an older or unfit patient population. And you can see here that the PFS was better with ibrutinib and venetoclax, as well as the complete response rate, not surprising, versus obinutuzumab and chlorambucil. But the reason I bring this up is that most recently, this has actually led to the EMA approval of ibrutinib and venetoclax for adults with previously untreated CLL. So this is now approved overseas. Now, when we talk about safety, obviously this is important because Deb talked about initially the toxicities of both the BTK inhibitors, but also venetoclax. And even though these are time-limited approaches, we know this from chemoimmunotherapy. When you pile drugs on together, there always is some additive toxicity, and so it's important to keep that in mind. So from the GLOW study and from the Captivate study here, for the GLOW, there were similar rates of grade 3 or more adverse events, 76% for the ibrutinib venetoclax versus 70% versus obinutuzumab chlorambucil. And then in the SAEs, greater than 5% of patients on each arm. Infections a little bit more with ibrutinib and venetoclax, 12 versus 8.6, and AFib certainly more with the BTK inhibitor, not surprisingly. And there was a small 2% of patients in the ibrutinib venetoclax arm that were discontinued due to atrial fibrillation. And remember, this is time-limited therapy, so keep that in mind. In the Captivate study, most of the grade 3 AEs were neutropenia, so 33%. So again, more myelosuppression, so keep that in mind, and hypertension with the BTK. Dose reductions of ibrutinib were in 6% of patients. In the venetoclax arm, with venetoclax in 11%, and in the combination in 4% with both ibrutinib and venetoclax. So just keep that in mind. So the combinations we know are highly effective with high response rates, and the PFS looks really nice. But you have to think about that depending upon the patient that you're enrolling on the oral combinations in terms of safety and for some of your older patients. The early experience, we talked a little bit, Deb had alluded to about debulking. And so one of the issues that comes up with CLL14, of course, with the venetoclax obinutuzumab is if you have a high-risk patient, of course, you can debulk with obinutuzumab starting as a lead-in for the venetoclax if you're going to do it that way. But we all know that you may have a nice infusion reaction with the obinutuzumab. So there is some pros and cons a little bit of that. But in your high-risk patients, if you need to, you're going to admit them and hospitalize them. When you're doing the oral combinations, it's a lot easier to lead into the venetoclax this way. So with ibrutinib, again, it was a 3-month lead-in with the Captivate study prior to starting the combination with venetoclax, and there's no doubt it reduces the tumor lysis risk in your patients. So you can see here, after 3 cycles of ibrutinib lead-in, 90% of patients that were previously high risk, only 2% remained high risk before their initiation of the venetoclax ramp up. So it makes it certainly easier then to transition those individuals when they're starting venetoclax to certainly do that as an outpatient when they're now not high risk anymore. So it definitely makes it a little bit easier to transition them onto venetoclax-based therapy. As I said, those 2 examples were really only 2 of many trials that are looking at oral combinations. There are obviously studies, doublets and triplets, looking at the second generation covalent BTK inhibitors, both with acalabrutinib and zanubrutinib. You have AVO, which is acalabrutinib, ven, and obinutuzumab. You have a MAGIC study, which is we'll be looking at acalabrutinib and venetoclax as well, and then the Sequoia RMD, which already is enrolling a large amount of patients with zanubrutinib and venetoclax in high-risk CLL patients. And I'm going to pass it over to Deb to talk a little bit about optimizing sequencing of these agents.
Yeah, and thanks for that introduction to the combination studies, because what a lot of people are asking now is, okay, so we've got two great classes of drugs. If we use these up front, then what do we do once the patient relapses after this therapy? And I think decision-making is a little bit more complicated in the second-line setting, but key items are what therapy have the patient had before and what was the reason for discontinuing therapy. Because you'll see a lot of patients discontinue, especially ibrutinib, secondary to toxicity or intolerance. There have been real-world reports that say that 40% of people discontinue therapy over time, and this is largely driven by toxicity. And again, the incidence of these adverse events is greatest within the first 6 months. And so again, counseling these patients, if you can get them through that 6-month time period, potentially they will not come off of therapy secondary to intolerance. And so in these patients who have had, intolerance to one BTK inhibitor, such as ibrutinib, they still can receive therapy with acalabrutinib, and I'll go over some of that data and sequencing and the effect of toxicity in the second BTK inhibitor that they've seen. Of course, disease progression is a little bit different story. When you have a patient that's progressing on covalent BTK inhibitor, Nicole already mentioned the BTK and PLC gamma 2 mutations, and those are going to confer resistance to all of the currently available BTK inhibitors and these drugs such as ibrutinib, acalabrutinib, zanubrutinib. And so obviously if somebody has progressed on it, you would not want to use another BTK inhibitor. You'd want to go on to a different line of therapy. And I have some data to show about venetoclax in this setting specifically. Nicole kind of introduced the concept of double-refractory CLL, so patients who have had both BTK inhibitors and BCL2 inhibitors. And she highlighted the data that very short survival and next line of therapy after those at only 5.5 months. Of course, there are BCL2 mutations as well to consider. And, a lot of times people ask about, would you check for these mutations before starting? Because I know that that's not available at every center. I personally do check for mutations before I'm considering re-challenging somebody. This is going to become really important also because, as you guys know, venetoclax therapies are fixed duration. And so, when you stop after a year of therapy, let's say you want to maybe consider retreating somebody with venetoclax therapy. I think it's a good idea to know whether or not they have developed resistance mutations during their time on therapy so you can predict their response and would not put patients who are resistant back on the same therapy. So this is data from a phase 2 study looking at patients who discontinued ibrutinib secondary to intolerance. Some of the important reasons for discontinuation are listed here. And then what it shows is how many patients actually had that side effect recur again once they started acalabrutinib therapy. And there were some people that did have a recurrence of the same toxicity, but almost in every single case, these were at a lower grade. And so it was more tolerable for the patient. And so this is a safe option if a patient has become intolerant to ibrutinib. Acalabrutinib should be an option based on this study. There was a similar phase 2 study done with patients who had received either ibrutinib or acalabrutinib and came off for a toxicity, which some important and key ones are listed here on this slide. These patients were treated with zanubrutinib, and you can see that very few, only those who are listed in blue, had a recurrence of the same toxicity. And you can see, so arthralgia, atrial fibrillation, fatigue, myalgia, and rash had a few, but the vast majority, 88% of the toxicities that caused them to come off one of those drugs did not recur when the patient was on zanubrutinib. So also, zanubrutinib is not yet approved for CLL. It is approved in mantle cell lymphoma and can be sometimes procured off-label if you have a patient that is has shown intolerance to both acalabrutinib and ibrutinib therapy. Here's the data from a phase 2 study looking at venetoclax in those patients who came off of ibrutinib secondary to being refractory or intolerant. This is a really high-risk group of patients with a median of 4 prior therapies. Half of them had deletion 17p, so really high-risk group, but still showed an overall response rate of 70% to single-agent venetoclax therapy. The 12-month estimate of progression-free survival was 75%. And so it does show that sequencing, venetoclax after a BTK inhibitor can have some really great efficacy. So what's really exciting is some new non-covalent BTK inhibitors. And what's exciting about this is we all know that BTK inhibitors are a really active class of drugs. So what happens when you become resistant to it? Well, unfortunately, this class of drugs has answered some of that question. Over on the left-hand side, you see kind of the binding schema for the covalent BTK inhibitors, including ibrutinib, acalabrutinib, and zanubrutinib. They do require this binding of the drug to the C481 moiety there on BTK. And when that mutates, which is the most common site of mutation, the drug can no longer effectively bind. However, with drugs like pirtobrutinib, I'll talk a little bit about nemtabrutinib, these next generation ones, they don't require binding to that site to work. And so patients who have this mutation still have a chance of having a really good chance of having a response to these next generation BTK inhibitors. And I'll share a little bit of this data. The Bruin study is a study where pirtobrutinib, which is formerly called LOXO 305, shows activity in relapsed or refractory CLL. It's hard to see the individual lines, but you can note that some of the lines are darker color and some are a lighter blue. Those darker blue lines are people who were on BTK inhibitors and came off for progression. And so you can see that they still had a really significant lymph node response. In fact, the overall response rate on the study was 68%. And what this graphic shows is whether the patient had a C481 BTK mutation or not, they actually had equivalent progression-free survival, which is really great news for these patients who have relapsed after therapy. The other subset analysis that was done on this study is there are several different combinations patients could have received before this, but really importantly, patients who are these double-refractory patients who've had both a covalent BTK inhibitor and a BCL2 inhibitor had a really great overall response rate to pirtobrutinib therapy. Of course, this drug is not quite available yet, has not been approved by the FDA for any indication, but there are rumblings that potentially mantle cell approval is coming soon, and so a really exciting drug to watch. Similarly, another non-covalent BTK inhibitor is called nemtabrutinib. This was formerly known as ARQ-531, and this drug also in a phase 1-2 study showed really promising results with an overall response rate in refractory CLL patients of 53%. There were a couple of different cohorts. Cohort A had a BTK mutation in that C481S region, and cohort B did not. And so you can see here I've shown the duration of response, and the median duration of response has not yet been reached in patients, and so once the patients do achieve a response, it is shown to be durable. In terms of progression-free survival, really importantly, all of these curves are overlapping, even though half of these patients have C481S mutations and half do not. And so really shows that in these patients that have refractory disease, a really great evidence of response. And what I haven't shown on this, but is also exciting about both this drug, nemtabrutinib and pirtobrutinib, is the toxicity profile. A lot of the side effects that we've been talking about with BTK inhibitors have really not been seen, and patients actually do very well. And now we're really going to transition into a case forum.
So just to kind of go over some of the data that we went through and a little bit talk about how we can utilize these agents and sequencing and sort of talk about different patient case scenarios where that may be applicable to. So here you have an older gentleman, 75. He has some comorbid conditions and has symptomatic CLL. His white count is 102. Hemoglobin is 9.5. His platelets are 120. He has both diabetes and hypertension. He has an unmutated IgHV. He has a deletion 13q. So certainly when we talk about, and again, Deb and I are both not going to talk about chemoimmunotherapy. So we're really going to focus on what we are using more predominantly in our practice, and I'm comfortable saying that both Deb and I feel that way. So with regards to this patient, would you consider continuous BTKI-based therapy or fixed duration, ven, obinutuzumab? Deb, what do you think?
And I think this is a really common situation that we see, older patient, what's the best option for them? You want to consider the toxicity profile of the drugs, and of course this patient already has hypertension. Might BTK inhibitors make that hypertension worse? It's possible. However, you also consider the mode of delivery of these drugs, and of course the venetoclax-obinutuzumab regimen does require coming in for IV therapy, and some patients, just would like to avoid that. In general, but especially during the COVID era, people like to avoid that. And so you can really, take into consideration both their personal preferences in terms of therapy and what side effect profile. Usually in older individuals, I most likely would go towards BTK inhibitor therapy. However, there's nothing wrong with using venetoclax and obinutuzumab in this population as well.
Yeah, agreed. I feel the same. These I think a lot of back in the day, for those of you who remember chemoimmunotherapy, our options were much more limited. Now that we have great options for these patients, and the efficacy is either of chronic continuous BTK versus the time-limited therapies are so good, that patient preference and what they logistically can be able to do, and then looking about comorbidities and social support and COVID and so on and so forth, I think patients have really good options and can then also tailor their needs based on the therapy and vice versa. So, usually unless there's something that's saying you can't do X because they have terrible kidneys or they have such difficult to control hypertension and cardiac issues that it makes you nervous, even with the second generation, that patients have many options that you can strategize along with them. So I think both options for this patient are completely reasonable. Now, what about if they're high risk? So again, you have it's the same patient, older individual, has diabetes and hypertension, but they have a TP53 or even a complex karyotype.
Yeah, and in this patient population, especially the TP53 mutated patients, I generally steer towards BTK inhibitors. And that's just, part of the reason why is, the data that you've shown. I think we have the longest follow-up data in these patient populations. And, several studies that have shown prospectively that these patients can have very, very long progression-free survivals while on BTK inhibitors. And, unfortunately, the longest follow-up data we have now for venetoclax and obinutuzumab-based therapy is really that CLL14 study. And there weren't a lot of patients with TP53 mutations on that. And you definitely can see a separation of the curve. So the patients that have, TP53 mutation don't have as long of progression-free survival with that regimen. And so, some people say, I don't know, maybe that's comparing apples to oranges because, the venetoclax and obinutuzumab therapy is a limited therapy. And, the majority of the relapses do come after patients stop therapy after that year. And so, a question is, are these patients that just need to be on continuous therapy? And since our BTK inhibitors are our continuous therapy, that's, the one that looks the best when we look at it in clinical trials. And so, I usually, push people towards BTK inhibitors when they have a TP53 mutation.
Yeah, I agree. I tend to do that now, although I know this is still very much up for debate, and given how well patients are doing, I think the one answer that I want to tell everybody is, for sure, these patients should be getting a targeted agent. So we may debate about which that targeted agent is, but they shouldn't be getting pure chemoimmunotherapy if they have a 17p or a p53. And I think that certainly should be changed for everyone. But I do think, given that we just have the longest follow-up. Now, of course, what I'm really interested in seeing is what our high-risk population does on the oral-oral combination. So, will they have a better PFS that then we'll all be comfortable saying, ooh, even in the high risk, we can do time-limited because they're getting both BTK and venetoclax. And so I think that's one of the subgroups with a lot of these combination studies that I'm going to be really, really interested in following long-term what they do compared to, let's say, obinutuzumab. So we'll have studies that are currently obviously looking at that and studies going forward. And so I think that's a population that we're going to want to watch, because maybe we can even offer then time limited to those individuals with high risk disease. So stay tuned for that. And then let's switch to a younger person.
Yeah, so I guess really very similar case, but just a younger patient. So a 59-year-old man with symptomatic CLL. Any preference in this patient population?
Yeah, I mean, it's not across the board, but my younger patients tend to really like time limited. They're willing to put in the extra effort. Usually the venobinituzumab may be busy up front, and if they're high risk and require hospitalization, there's no doubt that clearly there's a lot more monitoring that takes place initially. Once you get people through that first 2 months of therapy, though, it actually is a very easy combination to give. So usually my younger folks will like something that's time limited. I think it also depends on what the patient's goals of therapy are. And so if somebody wants to achieve MRD negativity and then have a period of time off of treatment, that becomes really important to them, then for sure they're going to choose a time-limited approach. That, again, tends to be, although there are some of my older folks who want that too. So I think, hence why I think oral is very appealing even to older folks as well. But certainly, I think this is one of those areas where I would choose a time-limited approach for the younger patient, with the goal of sort of getting them off drug and getting a deep remission.
Yeah, I agree. I generally steer the patients in this way. And, one thing we haven't talked about is financial toxicity. And so, of course, if a patient's insurance doesn't cover a continuous therapy and you're asking somebody to go on a treatment forever, and, maybe it's a $2,000 a month copay, that's just not sustainable. Although the assistance programs are actually quite generous, there are some people that kind of fall through the cracks in that and just can't afford that continuous therapy. And so that's something also to consider with these patients. And on the flip side, I do generally feel like my younger patients say, I'd like a time-limited therapy. I want to do something and be done with it. But I was actually really surprised the other day because I have a patient and she has some other, chronic medical conditions, and she said, you know what, like, I'm already on drug that I take every day, so what difference does it make adding another one? And so some people, just have different preferences. In the region that I serve, which is, the Mountain West, and lots of people have to travel, just starting a BTK inhibitor is actually quite easy for these patients because we just ship it to them and they start the treatment. We can get local labs. Whereas, if they live really far from the treatment center and they have to come in for these the obinutuzumab infusions and venetoclax tumor lysis monitoring, some of the things are just purely logistic. And I guess what we're getting at is, these patients have really good treatment options, and so we can really tailor that treatment to those patients. And so just kind of as Nicole was alluding to, we really have different goals of therapy. So the BTK inhibitors, the goal of therapy is disease control. These drugs do lead to prolonged progression-free survival. MRD status is not quite so important in these patients. Whereas, the fixed duration approach with venetoclax and obinutuzumab, I think of it as, hitting it hard and trying to get it in the deepest remission that we possibly can so that we can give people some time off of therapy. And that's, also the goal, one of the appeals of the BTK and BCL2 combination is, could we get that benefit of the BTK inhibitors, but then have that drug available in a fixed duration type of therapy so that you can maybe get the benefits of both. So how about this patient, and just assume that this is a patient that comes to you and, you're examining their neck. They've got, 7-centimeter lymph node conglomerate, just huge lymph nodes everywhere, and you're thinking, how high a risk are they for tumor lysis if you start them on venetoclax and obinutuzumab therapy?
Well, obviously they are high risk, and I'm not going to say that they couldn't do either, because they could with fixed duration as well. Clearly, and we're spoiled, so we realize that depending upon where you are, I have the luxury of having a leukemia service, so we bring them in. If this 59-year-old said I wanted time limited, they'd be coming in because they have bulky lymphadenopathy, and I'd be monitoring them for tumor lysis in the hospital setting. So it's something certainly that is easy to do, but this is where the oral combinations would have an appeal, right? So that if somebody has bulky disease, certainly, front-loading them with a BTK inhibitor and then debulking them and then doing venetoclax would certainly be an appeal for this type of individual. So certainly that's an option as well.
Yeah. No, I 100% agree with that. I think this, this young high-risk population is kind of an appealing group for me with those combination therapies up front. And, part of that, reason just to limit their risk of tumor lysis and still make it a time-limited therapy.
Okay, so let's go back to Robert, the older gentleman. So he's unmutated, he has diabetes and hypertension. He received acalabrutinib and then had progression, so that was his first therapy, and then got venetoclax rituximab in second line. And he progressed 2 years after the end of line of therapy. So remember, that venetoclax rituximab, per the Murano study, is a 2-year therapy. So he was on therapy for 2 years and then had 2 years of observation. I'm going to say he didn't progress right after. Let's give him 4 years. So he progressed 2 years after. Yeah, that's right, 4 years. So he had 4 years, which is pretty good. So what's next? Would you consider another covalent BTK inhibitor? Would you retreat with venetoclax or a non-covalent BTK inhibitors? This is some of the things we touched upon earlier.
Yeah, and I think that this case is going to become more and more common for y'all to see in your clinic. Because, now that these drugs have been around for long enough, you are starting to see some of these double-refractory patients. And, in terms of what's available, on the market right now, really, idelalisib is a drug that might fit into this. We haven't talked much about PI3 kinase inhibitors. I know they're not the easiest drugs to use, and a lot of people have really moved away from using them. I had somebody ask me, well, what about using bendamustine and rituximab in this patient? And I mean, I typically would not do that, and I'm just spoiled, and I have lots of clinical trials at my disposal, and I think that it's really important to enroll these patients on clinical trials, and so I typically wouldn't, but, if you're stuck and you don't have anything and that's, a drug that they haven't seen before, I would probably go to retreatment with venetoclax before I would go to a chemoimmunotherapy agent. I'd probably have about 10 things on my list before I would go back to chemoimmunotherapy, but that's, potentially a population where that would be useful. And then, of course, the non-covalent BTK inhibitors, I think, are really, really attractive due to toxicity profile and efficacy in this population. Of course, those are only available on clinical trial right now. And, the question about retreatment with venetoclax, I don't know if we know the answer yet. I mean, there's a prospective clinical trial that's being planned right now to maybe help us out with this. It's like, how do you consider, if somebody relapses 6 months after, if they relapse 2 months, 2 years after, like, when's the appropriate time to tell us that these patients might respond to venetoclax therapy again? And I think, of course, we don't have time to cover all the really exciting treatments that are coming forward, but, this may also be a population where CAR T cells are really exciting for these patients.
Maybe not for the 75 or 78-year-old, but maybe.
In Utah, 75-year-olds
okay?
are pretty young. They're usually skiing every day.
Well, then I should move to Utah because that's not New York City. But just to kind of go over this a little bit, clearly we know that if they failed a covalent BTK inhibitor, you're probably not going to go back to that. The retreatment with venetoclax, I think, is a viable option depending upon the time period. Obviously, there are studies, as Deb mentioned, that are going to hopefully address that because I think many of us would be uncomfortable retreating somebody with venetoclax if they shortly just relapsed right after venetoclax-based therapy. But there's a study that's going to look at the time period of when people finish their treatment with venetoclax and randomize them accordingly and take a look. So you can see, and I think it is important that you get venetoclax-resistant testing because certainly that would be a patient population then you probably wouldn't want to retreat with venetoclax because that would tell you something. The non-covalent BTK inhibitors, of course, when they become available, will certainly be an option. I think what's going to be really interesting is to figure out, and the playing field gets a little bit murky Because the longer we go, then we have to figure out what sequences and get long-term data on that. I guess it's a good problem to have for our CLL patients, because what we want to know is then what do we do? What's the appropriate way to sequence some of these therapies? And so should we go from covalent to non-covalent to ven,
Right.
for covalent, ven to non-covalent? These are all issues that need to be worked out. But certainly now we'll have another obviously class of agents that we can use for our patients that are progressing and developing resistant mutations to either covalent BTK inhibitors or venetoclax. So I think that's exciting for our patients. Just to go over this, I think that supporting strategies against BTK inhibitor resistance in CLL. So obviously, venetoclax, if you have a BTK inhibitor resistance, certainly we have data that you could use venetoclax, and we have data that you can go to a non-covalent BTK inhibitor, so I think that's good. The PI3 kinase inhibitors, as Deb mentioned, certainly, there was data from an earlier study that was reported that going to then, if you have a BTK inhibitor resistance, which is different than intolerance, that certainly if you then went to a PI3 kinase inhibitor, that the response duration was not as durable. So it's not to say you couldn't use it, it's just that it may be a shorter response duration. So just keep that in mind. And there isn't, although Deb mentioned about chemoimmunotherapy, we just don't have a lot of data, right? So we don't really have a ton of data going, well, if you've got a BTK and you got ven, can you go to chemoimmunotherapy? I mean, obviously our goal was to move away from more toxic therapies, but Deb's right. Depending upon where you are in your circumstances, who knows? You're going to use what you can use, and if that's all you got, if for an older patient, bendamustine might be suitable. Just most of us would tend to try to look for other agents, and we just don't have the data post-targeted therapies with chemoimmunotherapy. I think what we all think is not appropriate is that if you fail one covalent, going to another covalent BTK inhibitor, it does not make any sense. Okay, and so just to summarize from the whole presentation, obviously the BTK inhibitors are very effective, and they can have long PFS as evidenced by the earlier studies, both of the ibrutinib, now even maturing data with acalabrutinib and soon zanubrutinib. You can have a long PFS independent of your mutational status, and as long as you stay on therapy, right? So chronic continuous BTK, issues about intolerance can come up, and so but if you stay on therapy, patients can do very, very well. Venetoclax-based treatment combinations, it can clear most patients with their MRD after 1 year of therapy, and we know this from the upfront study. So patients can get deep remissions, and hopefully that will translate into a long response duration off therapy. Obviously, when we talk about sequencing of BTK inhibitors and BCL2, not yet clear which is the best way to start first, but we know that either option is effective when used sequentially. Obviously, we have more data with the use of venetoclax after covalent BTK than vice versa, but we'll have that maturing data with those folks who are getting ven-obinutuzumab in frontline more commonly. You'll have more maturing data with covalent BTK inhibitors in that setting as well. And then as data continue to emerge on these combinations, these oral, whether it be doublets or even in some studies triplets with the addition of the monoclonal antibodies, obviously there's continued opportunities for patients to have a fixed duration rather than continuous indefinite therapy. Hopefully that will reduce not only cost, but some of the long-term toxicities. Although we do have to monitor the toxicities in the combinations if you're giving it for a year or 15 months, whatever some of the studies are doing, because of the debulking. Clearly there's going to be enhanced toxicity, and those patients might need to be monitored more closely, similar to what you're doing with ven-obinutuzumab. And hopefully, again, important management of the toxicities of these agents. They're great agents for our CLL patients, and if we can get them through the toxicities, the patients are currently doing well. And this is what's improved the overall survival of patients with CLL. I think that being said, we're going to see if there's any questions.
Yeah, one of the questions that we received from online, what's your intake about using Ven-G with unmutated IGHV, using obinutuzumab and venetoclax or BTK with high level of neutropenia, which might require hospitalization? And a question, should we avoid using obinutuzumab due to this limitation? I think it's a good question. However, obinutuzumab is a really highly active drug, and you can see there was a study we didn't mention, the CLL-13 study, which was a frontline study, and it looked at several different combinations, but one of the combinations was venetoclax with rituximab, one of them was venetoclax with obinutuzumab, and certainly we did see a much higher rate of MRD undetectable status in patients treated with obinutuzumab. And so, it is a little bit more toxic in terms of neutropenia and infusion-related reactions, but it seems like, in most patients, it's probably worth the benefit of doing it because it's such a highly effective drug. And of course, when you're using that regimen, the goal of it is a really deep remission. And it definitely looks like obinutuzumab can help you get a deeper remission with venetoclax therapy.
I think there's actually a lot of questions asking about the neutropenia, and even with the oral combinations, one just came in. And so I think, it sounds like what Deb and I do are similar in our practices. I tend not to try to take people off therapy or dose reduce them unless there's a reason. So if they have neutropenia, I also do not mind liberal use of growth factor. I know that's not everybody's practice. I think patients who have persistent neutropenia on therapy, whether it's venetoclax-based therapy or the oral combinations, then I'm going to want to know why. And those are the patients that I'll typically then do a bone marrow just to figure out, is there something that I'm missing? Some of these patients, particularly if, more commonly, we're just gaining our experience with the oral combinations, but patients who are on ven antibody, when they're later on, let's say, on just, venetoclax, and they may get neutropenic, oftentimes when I do if they're persistently neutropenic despite growth factor use, oftentimes it's because they're actually MRD negative, and then I can stop therapy. But the point is I try to, unless they're having infectious complications or there's an issue that I'm worried about that I have to hold and dose reduce, I do. But if they're otherwise doing well, I'll tend to give growth factor.
Yeah. No, I agree. And I had a fairly young patient that I put on venetoclax and obinutuzumab therapy, and I had, that similar situation where I just, no matter what I did, I couldn't get their neutropenia to recover. And, doing their bone marrow, they were completely clear of CLL. And so I actually ended their therapy early, and it's a big discussion with the patient, but in the end, she has now been off treatment for about 3 years. And so it was just such a deep remission that, and even I think we were only about, month 4 or 5 of the venetoclax obinutuzumab therapy. So it can happen that, patients just have a really great response.
So there's no doubt that there's going to be higher neutropenia with both oral or obinutuzumab combinations. But if you support your patients, give them growth factor, clearly if they're having no response to growth factor or persistent neutropenia or neutropenia and complications with infections, you're going to have to hold and dose reduce accordingly.
Yeah, and I don't know about your experience, but even when patients have neutropenia, it's actually quite rare for them to have neutropenic fever.
Sure.
And so, just kind of managing, expectations for, if it's not severe neutropenia, just trying to really get the patient through the treatment.
Agreed. And then just a final, let's see, we'll talk about, I guess maybe prognostic testing.
Oh, yeah.
With CLL.
I would love to answer this question. Just I have an interest
start.
in it. So basically, the question is, do you need to know IGHV status because it's not playing a major role in managing patients? I think that's it's a very astute question. I still think that it's really important because I think it helps with telling the patient about their prognosis and about their, chances of responding to therapy. It is true that, it's not quite such a decision cut point anymore because most of us are not using standard chemoimmunotherapy. However, in patients who have unmutated IGHV, I unless I was, had no other option, I wouldn't do chemoimmunotherapy, and so I think it's important there. And then, of course, I'm a big advocate for checking these labs at the beginning, right when you diagnose a patient, because those patients with mutated IGHV, you can tell them that they may be one of those patients that can live out the rest of their life without ever needing a treatment for CLL. Whereas the unmutated patients, they know that they're going to need treatment at some point. And, they can prepare for that. And of course, right now we have a really large national study going on through SWOG, which is called the S1925 Evolve CLL study, which looks at those patients who have high-risk disease and randomizes them to early versus delayed therapy with venetoclax and obinutuzumab. And how you determine if they're high risk, it depends on their CLL IPI score, and you do have to have the IGHV status in order to calculate that. So I still do think it holds a lot of important prognostic information for the patients.
I agree. I tend to test everybody as well. So just to summarize, because I think we're over time, I want to thank you all for attending, and obviously, please feel free to, there are slides and things to view and polling questions, so you can submit your post-test evaluation for credit. You have slides and practice aids available as well. And thank you for joining us. Have a good rest of the meeting.
Thanks very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XPA860. This activity is supported by independent educational grants from AstraZeneca, Pharmacyclics LLC, an AbbVie company, and Janssen Biotech Inc., administered by Janssen Scientific Affairs LLC, Lilly, and Merck & Company Incorporated.